Happy to be back in Vietnam after COVID. I always enjoy coming to different places. This is my first time in Da Nang, and it's beautiful beach, wonderful. So maybe this is where I should do my summer vacation instead. English is a foreign language for you and for me. So if I'm going too fast, ask me to slow down. Feel free to ask questions anytime. Okay? This is a very new method, so sometimes if you don't get your questions answered, then it's difficult to follow what happens later. So I will discuss single fiber EMG. And I have a surprise. I have brought with me two guest speakers. You will see them soon. Okay. Single fiber EMG was developed by Professor Erik Stålberg and Professor Jan Ekstedt. They were students of pharmacology, and they were interested in muscle fatigue. And as a result, they wanted to measure the propagation velocity in the muscle fiber, wanted to see how it changes because of fatigue. And that's why they developed single fiber electrode. And as they were doing studies, they realized that this can be used to study neuromuscular transmission. So that's the beginning of single fiber EMG. It did not start for neuromuscular transmission. It started for something completely different. And so Professor Stålberg wrote his thesis. His thesis is propagation velocity of action potentials in muscle fibers in situ. Okay? So this is Professor Erik Stålberg. Professor Ekstedt continued with other things. He did not stay with EMG. He's also done a lot of work. So single fiber EMG, what are the things that we are measuring? We always talk about jitter, which measures the efficacy of neuromuscular transmission. Okay. It is more sensitive than repetitive nerve stimulation. The second parameter that we don't typically talk about is called fiber density. Fiber density is very sensitive to study the muscle type grouping. Fiber density measurement is done volitionally. So you ask the patient to contract the muscle and you perform the recording. Jitter analysis can be done by volitional activity or by using electrical stimulation. Okay? So two different measurements, very different recording techniques. Single fiber EMG is also used in research. For example, it has been used to study the H reflex or blink reflex, to study whether it is a monosynaptic reflex, oligosynaptic or polysynaptic reflex, etc. And single fiber EMG also led to the development of a technique called macro EMG. And I will discuss very briefly what is macro EMG. So let's start with some basics. We will start with a true single fiber electrode and then move our discussion into using concentric needle. So a single fiber needle consists of a 25 micron diameter wire, platinum wire, and it is exposed in the side port of this cannula. This is the bevel of the cannula. You will notice that the recording surface is on the opposite side of the bevel. Very different from concentric needle, where your recording surface is in the bevel itself. Okay. It is roughly 4 millimeters from the tip, so it's not at the tip, it's 4 millimeters behind. You always need two recording surfaces in EMG. We call it active, reference, and we obviously need the ground. So the small recording surface is your active. So this is your active recording surface, and the cannula behaves as your reference. So everything is built into the needle. We use different settings when we perform single fiber EMG. So first of all, we use something called amplitude trigger and delay. This is something that can also be used in needle EMG program. This is used to capture electrical activity from a single motor unit. And this is where you will be able to see a cross over here. So anytime the amplitude exceeds that horizontal level, we will capture the signal. Our filter settings are 500 Hz for high pass and 10 kHz for low pass. In our normal EMG, our high pass setting is about 10 or 20 Hz. So our bandwidth is much less. This is useful to exclude activity from distant motor units. We change our gain setting from 100 to 1000 microvolts, depending upon the signal amplitude. These signals do have high amplitude because you are using a very small recording surface. So although you are recording from a single muscle fiber, your amplitude can be as much as 3-4 millivolts. Okay. And finally, our time base, we adjust it 0.5 to 2 milliseconds per division. In our routine EMG, the time base is 10 milliseconds per division. So essentially, we are expanding the sweep so we can see the potentials better. Okay. So let's look at this example. You can see the gain over here, the time base. This is the potential, and let's listen to it. Here is our trigger. Listen to the sharp, crisp sound. Okay. It has a roughly biphasic or triphasic waveform. You see, this is phase 1, phase 2. It is biphasic or triphasic. It has a very short duration, maybe about 1 to 2 milliseconds. This is important to know when we perform the recordings. That way we can differentiate what is a true single fiber potential versus something else. So that's the way the single fiber potential looks like. A biphasic or triphasic waveform with amplitude of 200 to even 2000 microvolts and a short duration, about 2 milliseconds. Okay. It looks very different from a motor unit potential. So that's a summary of the waveform. And another important parameter that we look at is the rise time, which is the time it takes to go from the positive peak to negative peak. When you are very close to a muscle fiber, the rise time of a single muscle fiber action potential is less than 300 microseconds. Okay? So that's what we are going to look for when we make our recordings. Any question on the basic single fiber potential? Okay. So let's look at what did we call the recording territory of the single fiber electrode. This is a classic slide. This was a special experiment. I think this was a mouse muscle where they stimulated one axon for a very, very long time. As a result, the muscle fibers were depleted of glycogen. So after stimulation, they sacrificed the animal and stained the muscle for glycogen. So now you can see muscle fibers of a single motor unit. See, they are not clustered together. Before single fiber EMG, we used to think that fibers of a motor unit are in a cluster, like a cluster of 20 fibers here, a cluster of 20. And that is what was called a subunit. With single fiber EMG, we realized that the muscle fibers are distributed over a much larger territory. Okay? And they do not have a tendency to form groups. So that was a major change in our understanding of motor units from single fiber EMG. Next, all electrical fields, when we record them, they decrease in amplitude. Okay? If I am speaking without the microphone, person on the first table will hear me loudly. Somebody in the back, it will be very faint. This is natural. Single fiber potential also decreases in amplitude as you go away from the fiber. And what we found out based upon recordings is that if you are more than 300 microns away, see, that's a semicircle with 300 micron radius. If a fiber is more than 300 microns away, then the action potential amplitude is very small, less than 200 microvolts. If a muscle fiber is inside 300 microns, then it has an amplitude more than 200 microvolts and a rise time less than 300 microseconds. So now, by looking at action potentials, we can find out how many of them are close to the needle tip. Okay? So that's what is done when we do fiber density measurements. So we place the electrode close to a muscle fiber and we count the time-locked action potentials. 1, 2, or whatever. Okay? So let's look at the technique of doing fiber density. So here is our first guest speaker. This is Professor Donald Sanders from Duke University. He did a lot of work on myasthenia. He used single fiber EMG. So let's look at how do you do single fiber EMG in the EDC muscle. Okay?
The electrode is inserted into the muscle while the patient slightly activates the muscle. The electrode is positioned close to a single muscle fiber, and we know.
So, again, look at the angle of the needle. Concentric needle, we usually go like this. In single fiber, we go at an angle because you are recording from a very small area. If your needle slips just a little bit, you will lose the response. But if the needle comes like this, even if you change a little bit, you will still be next to the muscle fiber. Okay? So again, from here, if the needle slips, this is a fiber, this is a needle. If it slips, you are away from it. But if you go like this, see, now you are closer to the muscle fiber, much longer. This is something really important because you have to change your approach when you do single fiber. Single fiber EMG takes a long time. So you don't hold the needle like this. You always rest your hand like this on the patient. Or if you are doing it in the face, you rest your hand on the patient's head. That way you can hold the needle steady for sufficient time. Okay? So that's the important thing. You hold the needle like a pen, but you insert it at an angle. And there are two things that you are going to do. You either move the needle in or out, or you rotate it like this. Okay? Because then it will change the position of your active electrode in different directions. So when you look at this video, notice how his fingers are moving. The needle is going this way, and you will also notice a rotation of the needle. Okay. At the bottom, you are going to see the action potentials, and we are trying to maximize the amplitude and count the number of fibers. Okay. Any questions on this basic practical approach? Okay. So let's listen to Professor Sanders.
Oh, it's close when we see a sharp, clear spike that doesn't get any larger when we very slightly manipulate the position. So we optimize the recording position of the electrode so that we get a maximum amplitude single spot.
So in fiber density, it is important that you maximize the amplitude of the potential. Okay? Even if you see a nice spike, you don't stop there. You adjust the position to get maximum amplitude. Only when you have got maximum amplitude, then you start making your measurements. Okay? So in this case, that's a single action potential.
At that point, we look to see whether there are any other spikes time locked to that triggering spike.
So that's a single.
Not, then we record this recording position as having a fiber density of 1. We then move to another site selected the same way. And if there are 2 spikes, we record.
Do you see? Now there are 2 spikes. And again, it is important to see that they are time locked. If they are time locked, they always occur together. That means they have common innervation. If you have got multiple motor units discharging, then their potentials are not time locked. So having time locked potential is critical in single fiber. So in this case, we call it 2 action potentials. And again, we look at the number of potentials with a rise time less than 300 microseconds and an amplitude greater than 200 microvolt. That means the fiber is within 300 microns, okay? So this is the way we do it at 20 different positions. We go to position 1, maximize amplitude, count how many potentials we have. Then we go to another position and a third position, and we do this 20 times. So here are examples. Let's count the fibers. 1, 2. So there are only 2 fibers that are time locked. they fulfill the criteria of amplitude and rise time. So on a piece of paper, we will say fiber density is 2. Local fiber density at that site. Sometimes we may see like this. Now you can see 1, 2, 3, 4, 5, and maybe there is a small fiber over here. So in this case, we will record the fiber density as 6. Okay. So earlier I showed you the cross section. Most often, when you position your needle, you will see only one fiber, okay, in normal muscle. In about 40% of the places, you may see 2 fibers, okay? So in most normal muscles, you see 1 or 2 time-locked action potentials. You do this 20 times, and then you take the average value, which is your fiber density. So let's go back into our previous recording. If typically we see only 2 fibers, why do I have 6 fibers? That is because of renervation. Because a motor unit died, we had denervated muscle fibers, and then we get renervation. So within that circular 300 micron, instead of 1 fiber, now we have 1, 2, 3, 4, 5, 6 because of renervation. So in this way, fiber density is the most sensitive method to investigate renervation. Okay? It is more sensitive than fiber type grouping assessment on muscle biopsy. Okay? Typical fiber density values are like 1.6 or less. On muscle biopsy, you will find evidence of renervation when fiber density is about 2.5 or 2.6. So this is the way fiber density can be useful to study renervation. And long time ago, we used fiber density as a criterion in the diagnosis of ALS. You wanted to show renervation, and increased fiber density was one method of doing so. Okay. Fiber density varies in normal muscles. Again, here is a illustration from Professor Sanders. And there are some muscles with high fiber density going up to 1.6 or 1.7, as I indicated. Some muscles, most often you get only 1 fiber or so. Fiber density also changes with age. So you can see on the x-axis, we have the age, and on the y-axis, we have fiber density from many control subjects. And you can see fiber density is higher in older subjects. And again, this is natural because as we get old, we lose motor units, and therefore there is some renervation. Okay. What that tells you is that if you got higher fiber density and you want to learn jitter analysis where you want to get 2 or 3 spikes, you should use older subjects for learning the technique. Don't try young people with myasthenia. Start by doing tibialis anterior in patients with, say, diabetic polyneuropathy. Then you can easily get 2, 3, 4 time-lock spikes for jitter analysis. Okay. And again, this is the effect of age, and you can see the tibialis anterior has a profound change in fiber density compared to other muscles. So that's the muscle that we recommend for learning single fiber lineage. Any questions on fiber density? Okay. Keep in mind, fiber density can be done by using a single fiber electrode only. You cannot use a concentric needle because it is based upon how fast the amplitude decreases. Okay? Now we go to the other measurement, which is neuromuscular transmission, jitter analysis. So I want to review a little bit of basic neuromuscular transmission before we start investigating jitter. So you all know a motor unit consists of all muscle fibers that are innervated by one motor neuron. When the motor neuron discharges, all muscle fibers respond by producing action potentials that we record as EMG, and we get a muscle twitch. And in order to maintain a steady contraction, a motor unit discharges in a continuous manner. Okay. Let's look at the neuromuscular transmission. So here you can see our myelinated axon over here. Then you have its terminal, which is called the buton. So this is the buton. This is the muscle fiber. This is the nerve terminal. And in between, you have the synaptic cleft. If you look at the muscle fiber membrane in the synaptic cleft, it is not like a straight thing. It has got a lot of folds. Those are called the junctional folds. This is where the neuromuscular transmission occurs. Those are called the active zones in the neuromuscular junction. Let's look at it more detail. So here is one such terminal over here. You can see the nerve membrane. This is the muscle membrane. This is the synaptic cleft. And this is your active zone. On the side of the active zone, we have the synaptic vesicles. Think about it like a football game. So this is your field in between, and here are players and here are players. But they don't go in the field until the game starts. So, this is the synaptic cleft. On the muscle side, at the top, you have the acetylcholine receptors. And at the bottom, you have the sodium channels. That's roughly the organization of the buton or the neuromuscular junction. So how does the neuromuscular transmission occur? It starts by the arrival of nerve action potential. And when the nerve action potential comes into the buton, calcium is transported from extracellular space to inside. Calcium is necessary for mobilizing these vesicles to the field over here. So now some acetylcholine vesicles came into the field, and by exocytosis, they are released in the synaptic cleft. Okay? So the nerve action potential arrives, calcium comes in, acetylcholine comes into the active zone, released. Now, when you release something, there is a high concentration of acetylcholine over here, it is going to start diffusing to the postsynaptic membrane. Anything that is in high concentration always moves away. So if I were to open a bottle of perfume, after a few minutes, you will be able to smell it because it diffuses. So as the diffusion begins and it starts coming close to the postsynaptic terminal, we also have acetylcholine esterase. And the job of acetylcholine esterase is to remove acetylcholine So it takes it away, converts it into choline, and sends it back for resynthesis. So we have a race. Acetylcholine is trying to reach the postsynaptic terminal, and esterase is preventing it. There's a balance between them. Okay? Some of the acetylcholine will reach the receptors. And when it reaches the receptors, it's going to open sodium channels. Sodium flows into the membrane, and that begins the so-called end plate potential. So this is our resting membrane potential, and we get a small depolarization. This is the end plate potential. And when the end plate potential reaches a critical threshold, you get a full-blown action potential. And this will propagate from the neuromuscular junction to both sides to the tendon. Okay? So that's how a muscle fiber action potential starts after an incoming nerve action potential. Now we are back into the process of recovery. So the nerve terminal repolarizes, calcium goes out. Calcium typically stays in the buton for about 200 milliseconds. Okay? Why is that important to remember? Because if you stimulate at interval less than 200 milliseconds, calcium will start accumulating and it will improve neuromuscular transmission. So that's why in repetitive nerve stimulation, we keep our stimulus rate to less than 5 Hertz. Acetylcholine will get replenished, and any muscle fiber membrane will repolarize, and now you are ready for another nerve action potential. So let's look at the end plate potential. This is a recording from an end plate in a patient with myasthenia. Again, this was provided to me by Professor Sanders. So this is very much like a nerve conduction study. We are stimulating the axon and we are recording the potential inside the end plate. This is not outside, this is inside the end plate. Okay. So you can see there is a little bit of stimulus artifact, nerve propagation, and then you get this response. It looks like decrement on repetitive nerve stimulation, but this is actually a single end plate potential. And when you stimulate repeatedly, you will notice that the amplitude goes down. Now this happens even in a normal end plate. Okay? And that is related to how much acetylcholine, let me just adjust this is coming in my face and I cannot see. Okay, this is more convenient to look at me. Okay, so you can see there is a decline in the amplitude, and that's because of reduced quantity of the vesicles. You see it in the first force stimulation, and then the vesicles get replenished. So that's why it kind of becomes steady. So this is what is called the rundown phenomenon. When you stimulate the first time, this is your end plate potential. Second time, third, fourth, it kind of reaches minimum, and then it kind of relieves, stays at the same level. This is the level that is required to produce an action potential. So when the end plate potential is higher than this, it will produce an action potential. So every time you stimulate the axon, you get an action potential. Okay? This is normal physiology. So even though there is a rundown, you do not see it on extracellular recordings. And the ratio of the threshold to the end plate amplitude is called the safety factor. It's about 2 to 4. Now in pathology, you do get the rundown, but now the end plate amplitude is less than the threshold, and therefore you do not get any action potential. And if you do not get any action potential, in repetitive nerve stimulation, you will get decrement. So that's the basis of decrement in repetitive nerve stimulation. Now let's see how it relates to single fiber. But before that, let's look at an example of decrement in myasthenia.
Study of the left ADQ, 3 per second stimulation, 9 shots.
And you can see how the amplitude decreased.
Decrement is approximately 45%.
Okay. So this is your end plate potential. This is where we stimulate. This is nerve conduction. This is the end plate potential over here. And then this is the action potential, just for your reference. So on the top trace, when we stimulate, we get a very nice action potential from the muscle fiber. Next time you stimulate, you develop the end plate potential, but it does not reach the threshold. And therefore, it just comes back to the baseline. We do not get any action potential. And the same thing happens on the third. So this is the basis for normal response versus decrementing response. But if you look carefully, you will notice that if you continue to stimulate, you do get action potential, but it varies in time. Sometimes it comes early, sometimes it comes late. So the action potential does occur, but at a different time. So if the action potential occurs, our compound muscle action potential will be normal, because the action potentials are there. There will not be any decrement. But when we look with a needle, or if we look at this phenomenon, this shows that the time variability among the action potentials is now increased. And that's the basis for jitter. Okay? So what we are looking at is how does the time between two muscle fiber action potentials changes on successive discharges. You follow the concept of jitter? It's a variation in time that we are going to quantify. Okay. So the same thing is shown over here. This is our threshold for generating an action potential. Here are the end plate potentials that blocked. This is where they produce an action potential, but there is a great variability in time. So there is jitter in all muscles. It is low in healthy subjects and it's increased in patients. Okay? So that's the reason when you have increased jitter, but it is not large enough for the action potential to block, single fiber EMG would be most sensitive to demonstrate abnormal neuromuscular transmission. If you are getting block, if you are getting big decrement, 20%, 30%, your jitter analysis is going to be, has to be abnormal. Okay? So in that case, you don't have to do single fiber. But if you do find that the patient maybe has ptosis, maybe has weakness, but repetitive nerve stimulation is still normal, and you strongly believe the patient may have a primary neuromuscular junction disease, that's when you use single fiber. Okay? So now let's look at the volitional method of jitter analysis. So, once again, we are looking at the technique over here. We have the needle, we have the ground electrode, and so on and so forth. Now, the technique is different between fiber density and jitter analysis. In fiber density, you have to position your electrode to maximize the amplitude of one potential because you want to be next to it. That is not the case in jitter analysis. In jitter analysis, you would like to be somewhere in the middle of the two fibers so that you can record both action potentials for measuring jitter. Okay? So once again, this is at the cross section. If you are doing fiber density, you place the electrode over here, you maximize the amplitude. Fiber density is 1. To do the jitter, we try to position it between the two electrodes. So we'll notice that this was the fire potential from this. As we move the electrode over here, it became bigger. And the potential from this one, which is over here, became smaller. The idea is that you need to get two decent potentials. They don't have to be maximum, but so long as they are sharp, they have a short duration, fast rise time, that's okay. Okay? So keep that in mind. That's why we never do fiber density and jitter at the same time. We do the jitter study, then we will do fiber density. Because otherwise, if you are doing jitter, you will start overcounting fiber density because you are always going to have two fibers. Okay? So, let's look at single fiber EMG with voluntary activation.
Jitter measurements can be made in many muscles in the body. The facial muscles are particularly useful in assessing myasthenia gravis. We're going to do jitter measurements during voluntary activation in the frontalis muscle. This is a particularly useful muscle because it's frequently abnormal in myasthenia. It's an easy muscle to identify and to make recordings from, and it's an easy muscle for the patient to activate at varying levels. All the patient needs to do is to open the eyes.
Okay, so frontalis is an important muscle because when you get ptosis and other things, that's the muscle you're going to investigate. Typically, we look at frontalis. Some people look at orbicularis oculi. Either muscle is fine. Okay. Again, what I'm trying to demonstrate over here is the technique. How do you activate the muscle? How do you control the activation? Okay.
And look up to a varying degree. We'll start by looking at the lateral portion of the frontalis.
So with frontalis, we have the lateral portion, we have the medial portion. We like to investigate both. Okay.
This is a very thin muscle and therefore needs to be approached with the electrode, the needle electrode, very oblique.
So once again, look at the needle. I mean, you cannot go into frontalis over here. You cannot go perpendicular. You have to go sideways. This is your amplitude, trigger, and delay line. We are 1 millisecond per division, 100 microvolt per division.
Here we see a low amplitude potential.
So if you look at it, it's 100 microvolts, and our amplitude over here is 100 microvolts. So that's not a good position if you are going to do single fiber. Okay? So you need to have good amplitude. So we try to adjust the needle position.
We will adjust the electrode to maximize its amplitude.
So now you can see this amplitude, this is 200 microvolts per division. This is about 8 or 9 divisions. So the amplitude is like 1800 microvolts. It's a very high amplitude signal. 1 millisecond per division, if you look at the duration, it's about 1.5 milliseconds. It has a very sharp rising edge. That's the way single fiber potentials look like. And that's the kind of potentials we like to use for analysis. We change the gain. So that's a single. We cannot measure jitter in this. You need 2 time lock potentials.
Single fiber action potential.
Note how the amplitude changes with slight rotation of the needle.
So now he's rotating the needle. So when you rotate the needle again, you can bring it close to a muscle fiber. Again, that's good amplitude, 1
It's
millivolt.
important to test the muscle over its width, particularly to record from the medial portion of the muscle, in which we frequently find abnormalities, even when the lateral portion is normal.
So now we are in the medial portion of the muscle.
The subject is looking upwards to maintain a steady contraction of the muscle. And at this site, many different single muscle fiber action potentials can be seen.
So, if you see there are many potentials that are coming, you ask the patient to relax, okay? The trick in single fiber EMG is to advance the needle to get to the active muscle fiber. Not the other way. You don't just tell the patient, give me more force, because that's going to make a bad recording. So you look at a small potential that is going at the baseline, and then try to move the needle towards it, or away from it, or rotate it. Don't ask the patient to give more contraction, okay? So you want very slight contraction. The other thing that we do is, in order to help patient activate in our labs, we often have spots on the ceiling. So we say, look at the red dot, look at the green dot, look at the black dot, because now they can see up and down, and you say, just stay focused on it. That way, you get a steady contraction. Or you can tell them, look at 9 o'clock, 12 o'clock, 11 o'clock. So these are some simple tricks that you can use for coaching the patient.
Even in normal muscle, the frontalis fiber density is high enough that we can usually find pairs of potentials without a lot of difficulty.
So this is all single.
Potentials with very short potential.
Now there are 2 potentials very close to each other. You can trigger below the baseline or above the
This
baseline.
is a pair of potentials.
And you see this waveform keeps changing. It's like a broad spike and then all of a sudden it splits. That is what increased jitter looks like. Because when the jitter is normal, everything looks almost exactly the same place. When the second potential starts moving, that is increased jitter. So that's our visual assessment.
And this is a pair of potentials in which
This is normal. Again, let's look at, okay. And now we go to another side and so forth. You can hear a distant potential.
The long interval produces a rather hollow sound with a bit of an echo.
See, now we have three potentials.
We have a triple potential here, we're triggering on the second slide.
So now I'm going to introduce some concepts. The time interval between the two potentials is called the interpotential interval. Okay? So in this case, we can have an interpotential interval between 1 and 2, 2 and 3, 1 and 3, depending upon what we want to analyze. Usually, when the interpotential interval is more than 4 milliseconds, you may get high jitter because of something called velocity recovery function. I will not go into the details. Just remember that if you are getting high jitter and the interpotential interval is more than 4 milliseconds, we don't accept it. But if it is normal, then I keep it. Okay?
And the third pipe is at quite a distance.
Here's a pair of potentials with normal jitter. We're triggering below the baseline on the rising slope.
See, this is one moment, and you can see in the background there are other signals. They are not time locked because they were from other motor units. Okay? So, once again, so now that we have seen how the signal should be, this is how we typically do jitter analysis. We trigger on one action potential, and you see the second action potential is jumping to left and right. That's the variability that we are trying to measure, and that's jitter. Okay? So, two or more time lock potential, they should have parallel rising edge. That means from one discharge to next, the rising edge should stay like this. It should not go like this. Okay, that's tilting, and that will occur when your needle position changes. Okay, so parallel on all discharges, the rising edge should stay the same. And we like to record 100 such discharges. Then we measure the time interval between potential 1 and potential 2. That is your interpotential interval. So on the first discharge, let's say this was 950 microseconds. On the next discharge, it was 995. On the third one, it is 940. On the fourth one, 960, and so forth. We take the difference between consecutive interpotential interval and we ignore the sign. Okay? So 950 and 995, the difference is 45. 995 and 940, the difference is 55. So we calculate these differences and take the average value. This is called mean consecutive difference, or MCD. So when we talk about how much was the jitter, it usually refers to this calculation called MCD. There is another formula which is called mean sorted difference. Let's not get into the details of that. There are two formulae. Whichever one gives you the lowest jitter, that's what we accept for analysis. And this is what, long time ago, we used to do it manually from printouts. Now the machine does it for you automatically. So as I indicated, jitter is present in all muscles. In healthy subjects, the jitter is low. So let's start with low normal jitter, in this case 10 microsecond. Listen to the sound. It's a very static sound, doesn't change. If you superimpose the traces, you get very good superimposition. So that's an indication of low normal jitter. Now look at the superimposition and the sound. keeps changing. You can see the potential also jump. So this is slightly higher jitter compared to the previous recording. And the jitter was 38 microseconds. Okay? And when you superimpose, you can see it doesn't superimpose as well as the previous recording. Now this is abnormal jitter, increased jitter. Typically, normal muscles have jitter less than 55 to 60 microsecond. It does vary, but remember 60 as a kind of a number if you are not sure about the reference value. Look at the potential over here. See how it varies to the left and right? So superimposing the traces gives you the best appreciation of jitter. So this potential has got increased jitter, but it always comes there. Okay, sometimes it is late, sometimes early, but it's always there. And now, look at this one. One potential, and the second one comes and goes. This is increased jitter and blocking. So sometimes the second end plate was failing. So here is the nerve fiber, and these are the two end plates over here. The nerve action potential came. It was always transferred on this fiber, but on this fiber it was failing. So sometimes you see two potentials, and sometimes you see only one. So you understand the concepts? There is a normal jitter, increased jitter with blocking. Any questions on these three concepts? Okay. Blocking is something we suggest the operator should check and make sure. So you can raster your traces. You can always see the first potential. Here is the second potential. It is missing over here. And when it is missing over here, we look at the waveform of the first potential to make sure it hasn't changed. Okay. Increased blocking will typically occur when jitter is more than 100 microseconds. Most often, okay? So if you start seeing blocking with normal jitter, there is something wrong. It's a technical problem. Blocking is not seen when jitter is normal. Because what will happen is when you start doing jitter analysis, the machine will make a lot of calculations. And sometimes if there are problems with the signal, it will say jitter is normal, but there is blocking. That cannot be right. So the user has to take control of your analysis. So one of the things that is most useful in jitter analysis is something called the sequential interpotential interval histogram. So as you are recording the EMG activity, you make a plot of interpotential interval. So this variability is your jitter. When the jitter is normal, it doesn't go up. It stays kind of close. If the jitter is increased, now the data points will go up and down like this. So this is a very good tool to assess the quality of your recordings, the outliers, and other things. So this is something that we heavily rely upon in editing our data. Now, it is important to recognize that in a patient, you will have normal end plates, mildly affected end plates, and severely affected end plates. Again, this is from Professor Sanders. From one muscle, at one site, you can see the jitter is absolutely normal. At another site, the jitter is increased. And at a third site, the jitter is increased and there is blocking. What it means is that you need to sample the muscle extensively to find abnormalities of neuromuscular transmission. So a typical jitter study, we have 20 jitter values. So we go to site number 1, record a pair of action potentials, measure jitter. So at the first site, let's say it was 34. Then you go to another position, make second measurement. So you need to make a total of 20 jitter values. And then there are 2 ways of analyzing this data. One is based upon the mean value of jitter. So you can see that over here, the mean jitter in this case was 31 microseconds. And then there are normal values for mean jitter. The second strategy is to look at individual recordings and see if it is normal or not. So for example, the upper limit of mean jitter may be 40. So if the average jitter from 20 pairs is less than 40, it's normal. Upper limit of individual recording can be 60. So if any recording is more than 60 microseconds, then we will call it abnormal, that one side. So here you can see there were 2 recordings that had increased jitter. The way we have defined our normal limits is that you are allowed to have 2 abnormal recordings out of 20. So you make 20 recordings. If 2 of them are abnormal, we still call it a normal muscle. Okay? Because there is always some kind of trauma or something that has happened we don't know. So we always allow some exceptions. By the same token, if you find 3 or more abnormal recordings, then the muscle is abnormal. So let's say you start with the first recording, normal, second, normal, third, abnormal, fourth, abnormal, fifth, normal, sixth, abnormal. I already got 3 abnormal. I can stop the study. Okay? Otherwise, you have to continue up to 20. If you are not getting abnormalities, or if you don't have more than 2 abnormal ones, then you continue to do up to 20 recordings and look at mean jitter. Okay. The reference limits, again, they depend upon muscle and age. So criteria for abnormal, either you have increased mean jitter or you have increased jitter at 3 or more sites. Okay. So that was the volitional method. Now let's look at the stimulation method. So this is something that we use when the patient is uncooperative. For example, baby. They are not going to give you constant activation. Or the patient has tremor and other things, which makes it difficult to get steady muscle contraction. The principle is that this is very much like nerve conduction study. We stimulate the nerve, so this is we are using a monopolar needle for stimulation. This is the cathode, this is the anode, this is the single fiber needle, and now we are recording from orbicularis oculi muscle. Okay? So instead of having the junction activated volitionally, we are going to activate it by electrical stimulation. So here is Professor Stolberg explaining the technique.
We're going to show the stimulation with the surface electrode, and we're going to record from the frontalis muscle. First, it is rather convenient to find the place for the nerve, and we want to go as distal as possible, but not too distally so that we get.
Okay. So typically when you do the facial nerve stimulation, you stimulate somewhere over here, but that will activate the whole face. So that's why we stimulate as distally as possible. So the first thing we do is find out where is the nerve. So just using standard nerve conduction, you just stimulate the nerve and look for eye twitch. Okay.
Disturbances when we do the recording. I'm going to use a stimulation duration of 0.1 millisecond, and here I'm now increasing the stimulus.
Now I feel it.
And here I'm in a position where you can see a small jerking. I increase it so it should be easier to see. And then I go a few millimeters away, and it is still jerking, and here is much less. And here it seems to be the maximum. And here it is very little again, and here is nothing. Here's the maximum.
So you try to find the position where the nerve is, because if you stimulate right there, your intensity is going to be far less. Okay? Again, in stimulation single fiber, we are going to stimulate at very low intensity. We are not doing supramaximal stimulation.
And I stop that test and will glue on some surface electrodes. I have now placed the stimulating electrodes here.
So some people use a monopolar needle for stimulation. You can also use surface electrode. Whichever way you want to do it, it's up to you.
The cathode is here and the anode here. I use still 0.1 millisecond duration, and we want to see the twitching here. And
you can see the
with
twitch.
the surface electrode, we have to use a little higher stimulation strength. And in this case, now you see I go down with the stimulus, and I still see the twitches quite clearly. And we are at the 5 milliamp, and probably we can go down further when we get the recording going. Relaxing the face. Here, we're going now to increase the stimulus intensity, and using 10 Hertz, which is...
Okay, so we are stimulating at 10 Hertz. This is our needle, and this is our stimulus artifact. Okay? And then this is where we are going to get the muscle fiber action potentials.
The most common. Then we increase that to...
Look at the intensity, it is very low.
Yeah. And we will soon get a response here. And here we can see how I'm going up and down with the stimulus, how these three spikes come and go together. And that means that they are from the same...
So what you do is you increase the intensity or till you get a spike. And just at the threshold of stimulation, sometimes you get the potential, sometimes you don't. That's called a subliminal stimulation. You need to increase the intensity above that, okay? So controlling the stimulus intensity is very important in single fiber EMG.
Excellent. And this is now the position where we can make...
Now it is stable, and now we record the
Get
chip.
the recording. And if we increase the stimulus more, other fibers come in and are more or less disturbing to the picture. So we
This
want
is
to
not
have as
good.
few spikes as possible. One trick is also not to be right in the center of the muscle, the most twitching part, but out in the side of the muscle, where it's more likely to be clean signals.
So let's look at some waveforms. See, if you look at number 2, it looks like it is blocking. Because sometimes you see it, that is because the stimulus intensity was just threshold. And this is something that will happen in stimulation method. So you have to be very careful to make sure that you are stimulating the fiber adequately. Okay? So, stimulation method, it's a little tricky. Okay? Earlier, I was at low intensity and it looked like blocking. When I increase the intensity, now both potentials come there together. Now, if you increase the intensity, you get more fibers. That's subliminal intensity. So at subliminal intensity, you can get a false impression of increased jitter and blocking, and that's one of the major pitfalls in stimulation single fiber EMG. Okay, so that was a quick introduction to our basic techniques and so forth. Everything that we did, everything that we did was using a single fiber needle. So now let's talk more practical, because we are no longer allowed to reuse an electrode. Single fiber electrode, it used to be like $500, and we are not allowed to sterilize it. So the idea is that can we use a concentric needle for jitter analysis? So here are some of the issues. This is your single fiber electrode. It has a diameter of 25 microns, and it records from up to 300 microns away. This is a concentric needle. You can see it has a much larger recording surface. And if I were to place fibers, see, this electrode is already recording from 3 fibers. It really cannot record from a single fiber. So there are some things that we can do. We can perhaps reduce the size of this recording surface. So now we have a concentric needle with 0.02 millimeters square surface area. And now it is predominantly recording from this muscle fiber, but because of volume conduction, it could also record from here and here. We can further reduce the contribution from distant fibers by changing our high pass frequency setting. So the changes that we make is, this is a concentric needle that we use for quantitative jitter analysis. So these are also called facial concentric needle. Most people say, I use the red needle because it has a red hub over here. And we also use a 1 kilohertz high pass instead of 500 hertz. Jitter is measured between spikes because we are no longer recording from single fiber potentials. We have a larger recording surface. So we have to pay particular attention to the shape of the spike. Okay? And the normal values for jitter are different between concentric and single fiber electrode. Keep in mind, we cannot do fiber density analysis using a concentric needle. So let's look at some of the quality. We like the amplitude to be more than 50 microvolts. We like to display the signal so that it is at least 1 division tall, so that you can see the baseline noise and other things. Parallel rising edge, there should be no tilt. There should be no shoulders. I will explain to you what a shoulder is shortly. So, Look at this action potential. Parallel rising edge. We are at 200 microvolts per division, so this amplitude is 200. So that's good, more than 50. They have short duration, 500 microsecond per division, so just about 1 millisecond. So this is a good recording. This is also a good recording. The interpotential interval is short. This is borderline acceptable. We are at 50 microvolt per division. This is more than 50. This is just over 50. And it has got parallel rising edge. Okay? This is not acceptable. You see it rises and then it becomes flat. That is called a shoulder. So anytime you see something like this, you do not accept it for analysis. You can also see there is a wide change in the amplitude. This indicates interference from somewhere else. So this is not acceptable. Look at this. Here the shoulder is on the right side. But perhaps this is far away, so maybe I include this. But look at this rising edge. You know, it kind of comes over here and then it has a little bit of shoulder. So such recordings should not be accepted. This is too wide, 500 microseconds per division. This has a duration of 2 milliseconds or so. So this is a very, very composite signal. And here are the reference limits. So this is for the mean jitter, and this is for the individual jitter that I referred to. So again, let's look at some of the limitations. We cannot use it for fiber density. Stimulation technique is not efficient for large muscles. It's very difficult to get clean spikes. So the recommendation is not to do stimulation jitter in tibialis anterior, for example. You can use it for frontalis or orbicularis oculi, that's okay. Practical, you adjust the needle, record 100 sweeps. You can do analysis, manual or automatic, using peak or level, and that's something that I will demonstrate. You select the action potentials, you remove the outliers, you remove the interfering traces, and make sure blocking is confirmed manually. Here is the most important thing. Increased jitter and blocking does not imply a primary neuromuscular junction disease. If you have denervation and then renervation, during renervation, you will have new end plates, and they will have poor neuromuscular transmission. So you will see increased jitter and blocking in radicalopathies, ALS, many conditions. But if you get normal jitter in a weak muscle, then you can say this is not myasthenia. Okay? The diagnostic sensitivity is greater than 95% when two muscles are studied. Always study a weak muscle. If you are getting decrement, nice 20-25%, jitter analysis is not necessary. But if the repetitive analysis is normal, and if you still suspect a primary neuromuscular junction disease, now single fiber EMG is a good technique. Keep in mind, single fiber cannot differentiate presynaptic and postsynaptic. So Lambert-Eaton and myasthenia cannot, they will look the same on jitter analysis. Keep in mind that blocking occurs when jitter is increased significantly. So if you are getting a report that shows normal jitter with blocking, that means there is a technical error. And you can stop recording when the third abnormal pair is found. You don't have to record 20 pairs to demonstrate abnormality. But to demonstrate normality, yes, then you want to get 20 pairs. Normal limits vary by age and muscle. Okay, if you are trying to learn how to do single fiber EMG, do it in patients with reinnervated muscles with neuropathy. So tibialis anterior in a diabetic polyneuropathy is a good muscle to start learning. Coach the patient to maintain slight force of contraction, then adjust the needle. Don't just stick the needle and tell the patient, okay, give me some signal. It doesn't work. Listen to the sound. Many times you will hear the jitter before you see the pair. And rotate the needle to optimize the signals. When you are beginning, allow sufficient time for analysis. Most systems will allow you to record the signals and do offline analysis. Okay? But we like to make sure that we have got good quality signals before we let the patient go. Okay? And do not be frustrated if you are not able to record a pair of jitter. Professor Stolberg, it took him several hours to get his first pair of recording. Now he can do everything in less than 15 minutes, but his very first recording, he was in the muscle for about 15, 20, 25 minutes. So if you are having difficulties, don't get frustrated. Okay? I skipped macro EMG for the time being. Let's go through our demonstration part of it. You will find more information in the textbook, Single Fiber EMG, and Eric, Yoshe Trontels, and Don Sanders and we also created videos and other things. So these are two excellent resources. This is on the web. This is a textbook that you can use. So thank you. That's Eric, that's his wife, and that's me. I think we were in Dubai teaching a course at that time. So thank you very much. So what we thought we will do is actually do a demonstration of single fiber. Is that okay? Or
Yeah.
some? Okay.